globe down below. Just press on the globe and go on the English channel so that you'll be in the correct channel then.
So where's that for the group?
So if you go down below, just press on the globe and go on the let me just, sorry. So next to the share Q&A,
Yeah.
then the right-hand side of that, there's the more. Press on the more, you will see
Yeah.
a globe or interpretation, and just press on it and just use English.
English, perfect. Done it. Great.
We're nearly there, it's nearly time, so give it another couple of minutes. We have nearly 300 people online now. Perfect. Can see, it's great to see everyone from all across the world. It can see people saying hi from all different parts of the world on the chat function. It's great to see you again. I think this is webinar 79. We're not far off 100 now, isn't it? So let me open this. And it is 1 minute past. So let's start. So many thanks again for logging in and joining another Eye the Breast Book webinar. It's number 79. We're talking about sarcomas. We're talking about phyllodes, and we have great speakers from mainly the UK and Europe. So we have Karina Cox from Guy's Hospital in London. Martin Sanchez could not join us, but he has been great putting this webinar through him, and he connected me with colleagues from Italy to help with the webinar. So we have Belen, Urtueta. I don't know if I've said it correctly.
Yeah.
And we have also Valeria Masielo from Italy. We have also Jamie Vatish from Birmingham, and we have Micelle Wilkinson from London, all giving talks. Unfortunately, we don't have the lovely Ricardo Pardo. I think they have a family wedding, so you don't have a Spanish channel, and we don't have Akram also. He's in Egypt, so you don't have an Arabic channel today. But we have the lovely Tatiana, so if you want to listen to the talks in Russian, Tatiana is there. And we have also Michalis Sorotos. We have missed Michalis in the last two webinars, but he's back now. So if you want to listen to things in Italian, Michalis just is doing that, so you can go on the Italian channel. So let's start with the talks, and we'll do the 4 talks as usual, and then after that, we'll do the discussion. So the first 15 minutes are talk about pathology of sarcomas, and Belen will be doing that. Belen, the next 15 minutes are all yours.
Okay. Thank you very much for inviting me. Today I will talk about pathological aspects of malignant breast sarcomas. And I will start by saying that they are an extremely rare entity, less than 1% of breast tumors, with an annual incidence of 4.5 cases per million. The pathogenesis is unknown, except in some cases like chronic lymphedema and radiation in angiosarcoma, chemical exposure, and some genetic syndromes like Maifuchi, tuberous sclerosis that has angiomyolipoma in liver and kidney, and Cowden syndrome that has vascular tumors and lipomas also. They generally present as painless masses, though the vast majority of benign mesenchymal tumors are less than 5 centimeters. According to their genetic phenotype, we can distinguish between simple karyotype sarcomas that have a mutation or translocation that makes them quite monomorphous also in histology, and we also have complex karyotype sarcomas that they have numerous chromosomal aberrations besides the typical ones like TP53, and in histopathology they are characterized by nuclear polymorphism, high mitotic activity, and necrosis, in contrast to simple karyotype sarcomas. So the WHO also of tissue distinguishes between 4 tumoral behaviors that are benign, that can be cured with local excision and rarely recur, and if they recur locally, they're non-destructive, intermediate locally aggressive that can recur, rarely metastasizing with a very low risk but definite risk of metastasis, and malignant tumors, which we will talk about today. But let's remember that we are in a very complex organ, because when we talk about breast sarcoma, we must exclude Besides metastatic sarcoma, malignant phyllodes tumor, and metaplastic carcinoma, there are two really important entities when we talk about breast sarcoma. So even though virtually any soft tissue tumor can arise in the breast, I've selected some of them because it would be impossible for me to cover all of them. So I will start by the most common ones or the most interesting ones too. So I will start with angiosarcoma that represents one quarter of primary breast sarcoma, and it's a tumor that arises in endothelium of the blood vessels or the lymphatic vessels. And according to the etiology, we have two types: primary breast angiosarcoma and secondary breast angiosarcoma. Primary breast angiosarcoma typically affects young women without any history of cancer or risk factors, and it starts as a growing painless mass within the deep parenchyma, only given changes of color after it affects the skin, in contrast to secondary breast sarcoma that affects older women, and it's linked to chronic to radiotherapy, chronic lymphedema following mastectomy, and it arises along the surgical sites, and that's why it can give rashes, ecchymosis, and skin changes when it starts. So on cross-examination, these tumors are hemorrhagic, diffuse multinodal masses that range from different sizes. Normally, the better differentiated the tumor is, the more hemorrhagic it will be, in contrast to poorly differentiated tumors that are more fleshy, white, more solid. So histologically, they're very similar, but post-radiation angiosarcoma has been found to have high levels of MYC amplification. So I will show you a case of an angiosarcoma. This is from our institution, and it's from a 33-year-old patient who had a 7-centimeter mass. And here we can see these hematoma-like areas, and we can see also this well-differentiated area with these endothelial cells lining the vessels. But we can also see these more densely cellular, poorly formed areas with these cells that are more atypical. You see that one cell is bigger than the other, and there's marked atypia compared to the previous image. And what's also important is that you can see that it's infiltrating the adipose tissue. There's also an increase of the mitotic activity. And this is the surrounding breast parenchyma, which is also a proof that I'm not lying, because actually the patient had just given birth, and these are all the enlarged luminal cells with prominent vascularizations that are related to the pregnancy of the patient. So in immunohistochemistry, the tumor was positive for CD31. There is a very reliable marker compared to CD34, and it was also ERK positive. Another very useful marker when distinguishing it from a benign lesion is a smooth muscle actin, because it stains the pericytes instead of endothelial cells. That is why it's lost in breast angiosarcoma, because they are the endothelial cells that are proliferating. So moving on to the next entity, leiomyosarcoma, that is also very rare, and it can arise either superficial or deep within the tissue. Normally, the leiomyosarcoma in the deep breast parenchyma is larger than the superficial leiomyosarcoma, and the histology is the same that we find in other organs, with nuclear atypia, pleomorphism, high mitotic activity, and they stain for smooth muscle markers. We have 3 of them that are very useful: smooth muscle actin, desmin, and caldesmon. And it apparently has a better prognosis than other leiomyosarcomas in other organs, but this is also very limited to the rarity of these cases. In the differential diagnosis, we should include myofibroblastoma, desmofibromatosis, inflammatory myofibroblastic tumor, and metaplastic carcinoma. And we should also be careful because some of them can stain for EMA and keratins, and this can be kind of confusing. So another type of sarcoma that we should talk about is liposarcoma. Liposarcoma is reported in less than 50 cases. We should exclude malignant phyllodes tumor because it can have an heterologous liposarcomatous differentiation. And on gross examination, it's typically yellow-white mass But the higher the grade is, the more white areas, solid areas we will find. A very particular interesting case is mixed liposarcoma because it has this very gelatinous appearance when on cut surface. We have 4 subtypes. All of them have been described in the breast parenchyma that are well-differentiated liposarcoma, the differentiated, mixed, and pleomorphic. So well-differentiated liposarcoma, we have variable-sized adipocytes, and we have these fibrous areas where we can see this hyperchromatic irregular nuclei. In contrast to the differentiated liposarcoma, where we can see this high-grade spindle cell sarcoma with increased mitotic activity, non-lipogenic, but it transitions from a well-differentiated area of well-differentiated liposarcoma, hence the name, the differentiated liposarcoma. And both of them, well-differentiated liposarcoma and the differentiated liposarcoma, are frequently associated with amplification of MDM2 and very often CDK4, in contrast to a malignant phyllodes tumor with heterologous differentiation that doesn't have this amplification as described in literature. This is a mixed liposarcoma where we can see these cytologically bland ovoid to round cells, and they are embedded in this myxoid stroma. And what strikes also is the thin, delicate vasculature that's called chicken wire vasculature. And these liposarcomas are characterized by DDI-T3 genetic rearrangements, typically with FUS. Pleomorphic liposarcoma is essentially a high-grade sarcoma where we can see scattered lipoblasts that are these cells with lipid-containing vacuoles and these scalloped indented nuclei. So moving on to one of my favorite categories, because I think they are very important for the differential diagnosis, are chondrosarcoma, that is very, very rare. And obviously, we must exclude malignant phyllodes tumor and metaplastic carcinoma. And these tumors are characterized by a myxoid cartilaginous matrix with these cells that have this lacuna with variable cellularity, density, mitosis, and architecture, and they are positive for S100. And speaking of which, I would like to show you a case where we can see this cartilaginous matrix. This is a case from our institution, and we can see these scattered cells in between. And if you look at high power, so my question for you is, are we really sure this is a chondrosarcoma? Let's look at this cell. So I told you, okay, this is the cartilaginous matrix. We have these cells with this clear space, perimembranous. We have also a PIC, this bizarre cell. So could this be a chondrosarcoma? It could, but okay, let's perform immunohistochemistry. These cells are positive for cytokeratins, precisely high molecular weight cytokeratins. And these are other areas of the tumor where we can frankly see a more carcinomatous component with this nest of, frankly, more epithelial cells, because indeed, this is actually a metaplastic carcinoma with heterologous mesenchymal differentiation, in this case, chondrosarcomatous. So another very, very rare entity, primary osteosarcoma of the breast, limited also to very few cases, typically with a normal or increased alkaline phosphatase level compared to normal osteosarcoma of the bone. And same problem as before, because malignant phyllodes tumor and metaplastic carcinoma can have osteosarcomatous differentiation. So this is another case from our institution that belongs to a mastectomy specimen. It was an older patient with a 15-centimeter mass. And these are the images where we can see these cells, this cohesive, very richly vascularized, and these cells, they kind of have copious abundant granular cytoplasm. They kind of look like osteoblasts. And also these cells with multiple nuclei that kind of look like osteoclasts. And if we go to other areas, we can see this leaf-like fibroepithelial components of the tumor, because indeed, this is actually and malignant phyllodes tumors with heterologous elements, in this case, osteosarcomatous. Some other entities described in the breast are giant cell sarcoma, where we have these cellular nodules composed of these round to oval mononuclear cells that are positive for CD68, and we have these multinucleated giant cells, osteoclast-like. Apparently, they have a low malignant potential, but this is still very complicated to see due to the follow-up of these patients, and they lack mutations of H3F3A, in contrast to the counterpart of giant cell tumor of the bone. Some other entities that are important to discuss are dermatofibrosarcoma that arise deep in the dermis and may extend into the subcutaneous fat, but rarely extends very deep into the breast parenchyma. The skin is normally spared, but we can see sometimes ulceration if the mass grows, becomes bigger. It's a very monomorphic tumor with spindle cells without marked atypia that are arranged in this storiform pattern. And they have this peripheral fat entrapment that's very characteristic. And they stain positively for CD34. So like I said before, why are these tumors so monomorphic? Because again, they have this translocation, 1722, that produces this fusion called A1 with PDFGB, hence given this monomorphic aspect. And even though they're not very malignant, they have a high rate of local recurrence, so we should be aware of this entity. So moving on to one of the final entities, we have undifferentiated pleomorphic sarcoma, which was previously known as former malignant fibrosis histiocytoma. The incident is not very well documented. It has changed lots of names throughout the breast history, and it's normally characterized by marked pleomorphic spindle cells, storiform fascicular sheet-like patterns with a high mitotic activity. This was from a case from our hospital that the patient had been previously treated for a breast sarcoma with radiotherapy. Immunohistochemistry didn't show any markers of differentiation, so it was also a diagnosis of exclusion here. So we should be, it's basically a sarcoma that cannot be classified because it doesn't present any line of differentiation. So I would like also to talk about two entities that, even though they're not strictly malignant, I think they are very important to be aware of, that are desmoid fibromatosis, because it's locally aggressive and it recurs. It has a recurrence of 25-29%. Histologically, it's very blunt without pleomorphism and mitosis, but at the periphery, it has this infiltrative aspect that can be one of the reasons that it also recurs, and it has CTN and B1 mutations that we can see in immunohistochemistry because they produce an accumulation of beta-catenin that it should be membranous when there isn't this pathological translocation. And in the desmoid fibromatosis, it's nuclear, meaning that there are these mutations of CTN and B1. The tumor is CD34 negative and P63 negative. And I'm saying this because it should go into differential diagnosis with fibromatosis like metaplastic carcinoma. But in this case, fibromatosis like metaplastic carcinoma is positive for P63 and cytokeratins. But I think it's important to know that it can be in the differential diagnosis of malignant tumors. Moving on to the last entity, inflammatory myofibroblastic tumor. It has an intermediate risk, but it has a definitely low risk of metastasis, and it can mimic malignant sarcoma. It also affects young patients. It's also very blunt morphologically, with this infiltrate inside made of plasma cells, lymphocytes. They are positive for smooth muscle actin, and especially for ALK, because they have ALK rearrangements in 60% of the cases, and also ROS1. So I would like to finish with this image. I would like to ask you how we should behave in front of a spindle cell lesion with mitosis. That's atypical. Are we sure this is sarcoma, or would we like to do some more grossing of the specimen? Because here indeed, at the periphery of the lesion, we find this fibroepithelial aspect of the neoplasia, because this is actually a malignant Phyllodes tumor. So my key home takeaway messages are that we are in a very particular context, because we have to exclude other entities first, like metaplastic carcinoma and Phyllodes tumor, and some things that are basic can really be very useful, like extensive sampling of the breast, and morphology is still very important in these cases. So thank you very much.
Fascinating. That's a great talk. Thank you for that, Belen. So
Thank
for
you.
people that have just joined, it's great to see that there's more than 600 people online now. Unfortunately, Ricardo is not with us today because they have a family occasion. So there's no Spanish channel, but we have a Russian channel with Tatiana, and we have an Italian channel with Michalis. Now we'll do the 4 talks and we'll do the discussion after the talk. So Belen, if you don't mind, stop sharing your screen so that
Yes.
Jill can start sharing her screen. If you have any questions, please put them on the Q&A section. And if you don't have any questions, if you want to chat or to talk about things, just put them in the chat function. You can see it's quite busy, the chat function. I'm sharing some links to WhatsApp channel. It has about 1,500 people on that. But some people are telling me that that link is not working, because it doesn't work if you're from the computer. It works mainly if you're on the phone. And I'll share a link for one of the WhatsApp groups. So I will send all that also online, and please join those. Now, without any further delays, the next talk is going to be by Micelle Wilkinson, who's one of the sarcoma surgeons in the Marsden in London. And she's going to talk about presentation, workup, and surgery. So Michelle, the next 15 minutes are all yours.
Great, thank you. Can you see my screen okay and hear me? Can you hear me?
I can hear you all okay?
Perfect, brilliant. Good afternoon, everyone. My name's Michelle. I'm one of the sarcoma surgeons at the Royal Marsden Hospital, and thank you for asking me to talk on breast sarcomas. It's going to be a bit of a whistle-stop tour to do presentation management and surgery in 15 minutes, but we'll just go through the basics.
We don't see slides, we just see a screen. I think anybody else sees slides?
Let's try again.
Let's try again. Sometimes open the PowerPoint first, because I see RMH healthcare and share share health.
Sorry.
So if you share the full screen after opening the slides, it will work all okay, Michelle.
Okay, yeah. So I've opened it now.
Perfect. Yes, that's more like a slide.
Great, perfect.
Let's make it full screen, and then we'll be able to go ahead. Thank you.
So on mine, it's full screen. Is it not full screen on yours?
No, we still see the rest of your screen because you're sharing screen. So you see the rest of your screen. So just make it when you the green, yeah, put that. Perfect.
Great.
That's good. That's great. Thank you. Thank you, Michelle.
I can't. There we go. Okay, fine. So breast sarcomas. So why are these managed differently to breast cancers? So we've already had a talk on pathology, but these tumors, they arise from the mesenchymal tissue. They're not what we think of as most cancers, which are carcinomas that arise from the epithelial lining. So lung cancer, stomach cancer, bowel cancer, they all arise from the lining. Sarcomas arise from the flesh, the tissues that make up the rest of you, such as your fat cells, your muscle, your blood vessels. And because they arise from different tissues, they will not respond to the normal treatments that you use for other carcinomas. Most sarcomas will not respond to chemotherapy, except for a few exceptions, and they will not respond to hormone therapy. Because of that, surgery is the mainstay of treatment, and they require a wide excision for local control because other treatments do not have as much efficacy. So with breast sarcomas, the commonest types that I think we see, and I see in my practice, is probably radiation-induced angiosarcomas, of which, radiation-induced sarcomas, of which angiosarcoma is the commonest type. The other thing we see commonly is phyllodes tumors, which can range from benign to borderline to malignant, spindle cell sarcomas, and then we get into other rarer subtypes. So in the table, this is from an article published in Sarcoma, where they classified the frequencies of sarcomas that were seen in the breast. So how do these tumors present? So they often present as a mass. These can be rapidly enlarging, and they're painless, so they can be quite reasonable sizes by the time they're noticed. They can also be found incidentally on breast screening or other cross-sectional imaging. You don't get the typical breast cancer symptoms, so there's often no nipple discharge or skin changes associated with it. Radiation-induced angiosarcomas often appear approximately 5 to 10 years after radiotherapy, with a median of 7 years. They can present quite subtly with bruising of the skin and patchy changes. And on the right here is an example of a reasonably advanced radiation-induced angiosarcoma. And if you look at the top of the screen, often they can start presenting just with very low-grade patchiness, which will then rapidly develop. They can also be quite diffuse, and it can be difficult to define the extent of them. So when you see a patient with a suspected sarcoma of the breast, what do they need? So as we've just heard about pathology, this is one of the most vital steps. It can be very difficult to diagnose these patients and determine exactly what their pathology is. Therefore, all patients referred to us need to be reviewed in our pathology sarcoma MDT, where our expert sarcoma pathologists review the diagnosis, and these can considerably change the diagnosis from a sarcomatoid carcinoma, a poorly differentiated carcinoma, or upgrading or downstaging a phyllodes tumor. And one of my key takeaway messages from this presentation is that in a patient with new bruising of the breast, if they have a past medical history of breast cancer and radiotherapy, always beware radiation-induced angiosarcoma. So in the diagnostic pathway for these patients in a sarcoma centre, there's no magic or anything really different to what you would do in a breast clinic or in another centre. You need to take a good clinical history, emphasising any history of radiotherapy, the growth rate of the tumour and any symptoms the patient's having. You need to clinically assess them. Where is this in the breast? What is the size of the breast relative to the tumour? Is it mobile? Is it fixed to the pectoralis fascia? The patients will need imaging. This needs to be cross-sectional imaging to assess the disease itself. And when the pathology is confirmed as a sarcoma, they also require staging, either with a CT chest if it's for most sarcomas. However, angiosarcomas do also metastasize to the liver, so we would then do a CT chest, abdomen, and pelvis. Biopsy of these tumours, if they don't already have one, should be of a core needle biopsy. And as I've said already, this must be reviewed in a sarcoma MDT. So there's often delayed diagnoses of these patients, and the diagnosis can be challenging. So what is the problem with diagnosing these tumours? And I think really it's the rarity of them. Because they're so rare, there's a low suspicion by clinicians. So primary breast sarcomas account for less than 5% of all sarcomas, and they're less than 1% of all breast malignancies. In patients who've had breast-conserving surgery with adjuvant radiotherapy, the estimated incidence of radiation-induced angiosarcomas is reported anywhere from 0.05% to 0.3%. And in patients with a breast mass, they commonly go on a breast cancer pathway or to a triple assessment. And in these very busy clinics, the clinicians and the staff there very commonly see a high volume of benign breast disease, breast cancers, and non-specific breast pain. With radiation-induced angiosarcoma, the early presentation of it can mimic other conditions. It can mimic normal bruising. It can look like dermatitis, hematoma, cellulitis. And due to the patchy involvement, even when patients have a biopsy, these can be falsely negative. So staging and diagnosis needs to do the clinical exam, disease extent, size of breast, pathology and grade. If it's an angiosarcoma and you're unsure about the extent, you can do mapping punch biopsies and take clinical photos of these in order to help your further surgical planning. So really this one slide, this summarizes the management of the most common sarcoma subtypes that we see. So at the top, looking at benign disease, DFSP, so dermatofibrous sarcoma protuberans. This is a benign condition. However, it's a local problem and has high rates of local recurrence if it's not properly removed. So we aim to do surgery and for a 1 centimeter margin. And in patients who have a complete clearance, we actually can discharge them. However, the main thing to be aware of is fibrosarcomatous change. If this is present in the tumor, then this has now become a frank sarcoma and needs to be treated as a sarcoma. The other condition is fibromatosis. This is a condition that the management has changed substantially over the years, and we now don't operate on these patients in the first instance. We're lucky enough to have a fibromatosis clinic where the medical oncologist who reviews them. However, the first-line management, as per most guidelines now, is surveillance. If you operate and resect it, there is a very high rate of local recurrence. Nodular fasciitis is the other benign condition we see. A lot of these patients will spontaneously regress. However, if it's painful and progressive, then they may warrant resection. For malignant tumors, for a primary breast cancer, this would be surgery, plus or minus radiotherapy. Phyllodes tumor, again, is surgery, and we would offer radiotherapy if it's a malignant phyllodes tumor. Radiation-induced angiosarcoma does get more complicated. Surgery is still the mainstay of treatment, but the type of surgery, as I'll discuss later, can be very varied, and there's also a increasingly evolving role of neoadjuvant chemotherapy for these patients. So breast radiation-induced sarcoma, as we've said, it can occur in about 0.5% of patients, and a median time frame from radiotherapy is about 7 years. To be diagnosed as a radiation-induced sarcoma, it has to be histologically different from your initial breast cancer and occur 2 years after the radiotherapy. Angiosarcoma is the most common subtype, and then the management of these conditions, really the biggest question is what kind of operation to do. Do you do a wide local excision? Do you do a mastectomy? Do you do a radical mastectomy? Or what is quite common standard practice in America is to resect the entire radiation field and do a plastic surgery reconstruction. This can be quite morbid surgery, especially in an elderly population. So the problem with radiation-induced angiosarcoma, if you're trying to resect the entire radiation field, how do you know you're removing all of the radiation field with disease change in it? Radiotherapy for the breast is carefully planned, but it uses relatively crude external beam radiotherapy, and you will have off-target effects. How do you assess which tissue to remove? Your radiotherapy in these patients is from below the clavicle all the way down to the inframammary fold. The role of the radiotherapy, oh, sorry. Just lost my screen. Sorry, can you see? I clicked on something, there was a tab in the way, and then it removed my whole presentation.
That's okay. You just need to log in again. That's not an issue at all. And it's great talk so far. And there's lots of people. People are putting still questions. Natasha, Zakur, you're putting questions on the chat function. Please put them on the Q&A function so that we can see them all online. And there's also questions from Georgina about borderline phyllodes and things like that. That will be addressed by the talk by Karina. So there's still quite a few things to come, and that there's a new UK guidelines. And then we'll leave now Michelle to finish her talk. Thank you.
Can you see it again now?
Looks perfect.
Great, sorry about that. And the biggest problem with radiotherapy is there's currently still no biomarkers to determine radiotherapy change and predict the risk of malignancy. So this is a case presentation of a 70-year-old female who previously had right-sided breast cancer with wide local excision and radiotherapy 10 years prior to presenting. She came to our hospital with a rapidly growing painless mass on the left chest wall. She had a biopsy of this, and it was a very aggressive, poorly differentiated cancer, but it was unclear, because it was so aggressive, whether this was a metastasis from her original breast cancer or a sarcoma. We opted to do a wide excision of this in order to both treat it and to give us a better tissue sample for diagnosis. However, in order to do a primary resection and closure, it does require quite a wide excision, which we were able to do without a plastics reconstruction. This came back as an undifferentiated pleomorphic sarcoma, which was resected in clear margins. On review of this is likely to be off-target effects from her radiotherapy, and it was judged to be a radiation-induced sarcoma. So breast angiosarcomas are a very important topic. It's an aggressive disease, and we really need to improve outcomes for these patients. The main question is what margins, and I get asked that question all the time. Should we take a 2 centimeter margin, 3 centimeter, 5 centimeter? Is multimodality treatment better than surgery alone? There is no current evidence that being more radical with our surgical approach, however, improves surgical outcomes or quality of life for these patients. So the clinical question: do you do the standardized approach of removing everything, or do you individualize your approach to the patient in front of you? These patients, so on the left-hand side of the screen, we would offer a wide local excision. The middle one, we would offer a mastectomy. The patient to the right was offered a radical mastectomy and DEP reconstruction. So the idea of being more radical with angiosarcoma, the only real published evidence on it is this paper. In this, they argued that being radical with the resection improved outcomes. However, they did not define what being radical was. And if you look at the conservative group, there was actually about 25% of patients who had involved margin. So I would argue that was undertreated rather than conservative management. And although these tables did show improved local control rates and improved distant metastases rates, again, their definitions were vague, and the conservative group were undertreated. The other question is, how can you be sure to remove all of the radiotherapy field? This is a patient with very subtle recurrence of her radiation-induced angiosarcoma 1 year after her treatment. This would not have been removed with a radical resection, and there's no way to justify doing a radical resection if you don't know that you're removing all of the field change. So in this patient, this is a patient who presented with this very complex recurrence in her axilla. And I just wanted to highlight this for an example of management of these patients and how difficult it can be. So in August 2022, she had a right simple mastectomy for radiation-induced angiosarcoma. However, unfortunately, less than 2 years later, she developed a recurrence of the right chest wall. And then she underwent neoadjuvant chemotherapy with, as you can see from the middle picture, an excellent response, and had a resection with an LD flap. She had clear margins of over 1.5 centimeters, and the neoadjuvant tumor had an excellent effect, and only 5% of the tumor was still viable. However, despite this, she then went on to develop a recurrence in healthy skin from her latissimus dorsi donor flap, which we could not have predicted at the time. And this raised the question of what do we do about the off-target effects and the exiting radiotherapy effects in the axilla and back. So to highlight, with a patient with this type of disease, this can be resected with a simple mastectomy. And really why that's important is the length of stay for a patient with a mastectomy is often 1 night. The complication risk is very low. If you offer these patients a radical mastectomy with an attempt to remove the entire radiation field, their risk of complications is significantly higher, their opioid requirement is higher, length of hospital stay is 5 to 7 days. But it's a very difficult group of patients to manage, and we consider the patient and the disease burden in front of us. So over the last 2 years at the Royal Marsden Hospital, I looked at our data, and we've performed 28 surgeries for radiation-induced sarcoma of the breast, and it's quite evenly spread. So about 1/3 of patients were offered a wide local excision, 40% had a mastectomy, and 25% had an extended mastectomy with plastics reconstruction. Of those patients, the median inpatient stay was 1.5 days, 20% were done as a day case, and there was only 1 complication and no returns to theatre. So in these elderly, sometimes very frail patients, conservative management with a multimodality team approach can be very successful. This was an 81-year-old lady. She had a radiotherapy-induced angiosarcoma of her breast resected in 2019, and then developed a recurrence 3 years later, which was resected. Unfortunately, a year later, she developed a multifocal recurrence, and she was commenced on weekly paclitaxel. She then went on to have a resection of what was left of the chest wall recurrence and is still disease-free at 1 year. So she's had multiple local operations, but has had no evidence of systemic spread, and her overall survival has been 5 years. Really, I think the key point of angiosarcoma is that we need a better understanding of the biology and the relapse patterns of this complex aggressive disease in order to determine optimal management strategies. This is a disease with high rates of local and systemic recurrences, and it seems intuitive that a treatment plan that includes both of these may improve patient outcomes. And there's been a few papers over the last year that have highlighted the importance of neoadjuvant therapy and the good outcomes they can have. I won't go through that in detail. And this is just an example of one of my last slides to show that neoadjuvant chemotherapy, even in quite locally advanced disease, which is where we most commonly use it, can have extremely good outcomes for these patients. So in conclusion, breast sarcomas are rare but aggressive. They can be difficult to diagnose, especially radiation-induced angiosarcoma, which can mimic benign changes. Poor prognosis due to delayed diagnosis and aggressive biology, and therefore a high clinical suspicion is needed. Ultimately, we need to offer our patients carefully thought out patient-centered approaches to give them the best possible outcomes. Ideally, you would do clinical trials in these patients, but due to the rarity and the heterogeneity of the disease and presentation, this is not very easy to do successfully. Thank you very much.
That's a great talk. Many thanks, Michelle. So Michelle and Belen, there's quite a few questions on the Q&A section. If you can have a look at them, if there's anything that you want to answer live, just click on the answer live. We'll add to the discussion. Now, the next talk is about multimodal approach, and that has been touched upon by Michelle in the talk. And we have Valeria Masielo from Italy also talk about the role of systemic therapies and radiotherapy as a multimodal approach in the sarcomas. Valeria, next 15 minutes are all yours.
Thank you so much, Yazan. I really thank you for all your effort in organize this interesting initiative for sharing knowledge and scientific approach. Now I share my screen. Please let me know if you see the presentation.
It is there, so you just need to make it perfect.
Okay. So, good afternoon to everybody. I'm Valeria Masielo. I work in Fondazione Policlinico Gemelli in Rome. I am a radiation oncologist, but I work in a day hospital, so we have the possibility to manage the patient both from chemotherapy and radiotherapy side. Today the topic is very challenging, as we see in the next minutes. Sarcomas and phyllodes are very rare and have a very challenging implication for their management. So this is the index of my presentation. After a brief introduction, when we will point some clinical characteristics that are useful for some consideration about chemotherapy and radiotherapy in breast sarcomas and phyllodes tumor. We will move to some aspect of systemic treatments and radiotherapy. So, if we move to the introduction, as my colleagues say in the previous presentation, phyllodes tumor and sarcomas are very rare disease with unique biological features. If we consider the origin of both phyllodes and sarcomas, what we can say is that phyllodes derives from fibroepithelial neoplasm tissues and have a spectrum of behavior from benign to malignant presentation. In literature, 10-20% of phyllodes are described in presentation as malignant as incidence rate, while sarcomas derived from mesenchymal tissues. As we've seen from Belen presentation, we have at least 20 different types of soft tissue sarcomas that can be diagnosed also in breast tissues, in breast district, but half of them is reported in literature as angiosarcoma, both primary and secondary. The incidence is very rare in both groups. We talk about less than 1%, and in general, among all soft tissue sarcoma, breast cancer sarcoma are less than 5%, so are a rarity in a rare group of tumors. About possible risk factors, what we can say, there are some data that reports that phyllodes tumor are associated with pathogenic variants of p53 genes, so they are associated with the Li-Fraumeni syndrome. Instead, sarcoma can present both different factors that are described as linked to develop of sarcoma in breast tissue. We have both genetic factors. It's described that some Li-Fraumeni and some neurofibromatosis 1 persons can develop breast sarcomas, but there are also some factors that can cause breast sarcomas. For example, the first well-known is exposure to previous radiation treatments, but also exposure to chemical factors such as vinyl chloride, alkylating agents can cause possible etiology of breast sarcomas. Recently, we report in our retrospective review of multi-center casistic cohorts also the survival outcomes in a long terms of this disease. We will see this review in the next slide. But what we can say about prognostic in these two kinds of group of mesenchymal neoplasm of the breast. For sure, phyllodes presents a better prognosis. As we see, 10-year overall survival described in literature is around 90%, with a lower rate of local recurrence at 10 years. We are talking about 11%. Sarcomas present very bad prognosis. At 10-year overall survival is around 67%, with a rate of 10-year local recurrence around 30%. That signifies that 1 on 3 patients have a local relapse during after diagnosis and treatments. Also, clinical presentation is very typical and can cause some implication for diagnosis and treatment of this disease. For example, as we see, imaging is not specific. We have, especially in the early presentation, not a specific sign of the presence of mesenchymal tumors in the breast, not distinguishable from fibroadenoma or carcinoma. And the presentation is usually locally advanced with a clinical presentation with large size palpable mass that have a diameter more than 5 centimeters with presentation also of skin ulceration that can make the surgery very difficult, especially radical surgery when the presentation is so advanced. These critical points that we see have a lot of implication for the management when after the diagnosis, because the extremity rarity, the high heterogeneity in the group of tumor, the not specific screening cause a lack of consensus guideline with a high level of evidences. So all the indication that we see in the second part are derived from the soft tissue sarcomas guidelines, and the urgency from oncological and radiotherapy and in general from the breast sarcoma expert is the need of biomarkers that can predict us the response to treatment in order to design trial for more tailored approach. So let's move to systemic therapies approaching breast sarcomas. What we can say, as already said, the approach is extrapolated from general guideline of soft tissue sarcoma, in which we already find that there is not a univocal indication in administering systemic therapy with neoadjuvant and adjuvant finality. Probably because there are not so many evidences, but there are some suggestions about when administered chemotherapy, for example, in neoadjuvant setting, if we have the need to downsize a tumor that is still not metastatic and that can be led to surgery and enable also more demolitive approaches. And starting with chemotherapy could also offer an early control of micrometastasis. Adjuvant chemotherapy is very controversial because we have no evidences that all the patient needs this kind of treatment after surgery. There is not a strong evidences, but it can be considered, and according to guidelines, when we have locally advanced disease with aggressive features such as high-grade tumors with a large size, more than 5 centimeters, when the tumor is localized deep in the chest wall, when there is also the doubt or the confirm that the tumor is microscopic or macroscopic residual. And what kind of line of drugs are usually used in this kind of patient? Doxorubicin and ifosfamine is the most used schedule with a high level of evidences of efficacy. The same schedule is also the first choice schedule for patients who are not resectable and metastatic. And as we see in the ESMO guideline, this kind of approach needs to be prosecuted when the patient is in partial response in stable disease, since when there is the achieving of the maximum dose for anthracycline, progression or unacceptable toxicity. In case of progression, there are second choice approach, for example, gemcitabine docetaxel, as we see in the next slide, and there are some indication to antityrosine kinase drugs such as pazopanib. In 2025, my institution, my group of breast unit performed a deep review, an extensive review of the literature in order to put in evidence of all the indications that are present in literature about chemotherapy and radiotherapy for malignant mesenchymal tumors and sarcomas. And what emerged from this review is that for sure there are not randomized control trials that are specifically focused on primary breast sarcomas. So we have no trial designed for this kind of patients. All the study address the conclusion from soft tissue sarcoma general courts. And about adjuvant and neoadjuvant chemotherapy, the approach is the same of general guidelines of soft tissue sarcomas, in which the indication is for more locally advanced and aggressive disease, especially with aggressive features such as high grade and tumor larger than 1.5 centimeters. So in this review, we also report the trial with a high level of evidences for some schedules in soft tissue sarcoma. For example, the best known is the HORTIS-C trial, in which patients with a mixed kind of sarcoma were randomized to receive doxorubicin alone versus doxorubicin and ifosfamide. In this trial, the endpoint was progression-free survival, and it reached the statistical significance superiority for the combined arms of doxorubicin and ifosfamide, but the overall survival did not reach the statistical significance. For sure, we have to consider that the combined approach with double drugs is for selected patients, the patients who are fit, because it presents higher toxicity in administration of these two combo of drugs. And another trial of LMS0 study of Poitiers, randomized patient, always with mixed histology to receive doxorubicin alone, respect doxorubicin plus trabectedin, and what we see is that the combined approach of multi-drug can lead to a better progression-free survival. Obviously, this approach is reserved for patients who are fit to receive this combo, and at the present time we are waiting the overall survival data. An emerging approach in the next period is to use also anthracycline with of new generation. For example, adoxorubicin can vehicle anthracycline with less toxicity, and it was randomized in this trial with doxorubicin, and the results shows double progression-free survival with no change in overall survival. Probably the maintaining of a less toxic therapy can assure better survival outcomes. In patients who were pretreated and who are metastatic in progression, there are some data always on mixed cohorts of different sarcomas. And also here, although doxorubicin was randomized respect investigator choice, and what emerged is that the progression-free survival was better, probably because the vehicle of the drugs was better. About new approaches, there is also gemcitabine docetaxel that is an option reported also in guidelines. And thanks to the JEDIS trial, was randomized with doxorubicin in order to compare if there were not inferiority in terms of progression-free survival, and the trial was positive in this sense, but we have to think that the combined approach are more toxic during when administered respect monochemotherapy. Also, if there were not severe adverse events in this trial for the polychemotherapy arms. I reported also this study, the angiotax study, that is a phase 2 trial published on JCO, in which a patient with angiosarcoma were treated with weekly paclitaxel with primary endpoints designed as not progression at 2 months of treatment. And what showed the results is that at 2 months the patient have 74% of non-progression. That at 4 months was 45 and the 6 months 24. So there was in the first months during the therapy a maintenance of stability. And the trial enrolled not only the patient naive, but also the patient with the previously administration of treatment. So they have the same outcome in this sense. But the very interesting point of this approach is that we could combine it also with radiotherapy. We know that from the study, for example, of the lung, of the esophageal cancer, we can combine radiochemotherapy with paclitaxel. And this patient with locally advanced, with in progression or of new diagnoses that are not susceptible of surgery could be candidate also to radiochemotherapy, but obviously these choices need to be discussed case by case by a unity of expertise. About phylloid tumors, what are the evidences? In our literature, we also explore if there were some evidences in literature about administration of chemotherapy in patients with malignant phylloid tumors, and what we can say about it, that the role is very, very controversial. There are not specific guidelines about this kind of disease, and the administration of the chemotherapy should be reserved to specific case after consultation with expert center for managing of sarcomas. But we know also that around 20% of malignant phylloid tumors can relapse also in metastatic setting. So it's very important to individuate this patient with worst prognostic features that are candidate to chemotherapy in order to administer to them a treatment that could reduce the risk of develop distant relapse. And what kind of schedule were used in phylloid tumors? Usually in literature is reported to use doxorubicin and ifosfamide that have the highest impact of survival and activity in this type of tumors. There is also older systematic review published in 2019 in which the systematic review and meta-analysis were specifically conducted on patients with phylloid tumors, and they collect more than 600 of patients. What emerged is that patients who underwent chemotherapy were at the most patients with malignant phylloid tumors. that the schedule that were not doxorubicin and ifosfamide were which with worse prognosis, in which disease-free survival and overall survival were worst. And instead, in the study of China that was reported in the review, patient underwent doxorubicin and ifosfamide with less events of distant relapse and better overall survival. Let's move to the radiotherapy indication in breast sarcomas. Also here we conducted a revision of literature also in this sense. What we can say that in general, indication of radiotherapy for a patient with breast sarcoma are the same of soft tissue sarcoma. So they are extrapolated from general guidelines from soft tissue sarcomas. We know that breast sarcomas and malignant phyllodes have also a tendency for local relapse. It's also when we are very radical, but especially when the patient underwent conservative surgery. And it's reported that patients who underwent only surgery without adjuvant radiotherapy have a rate of local relapse around 20-35%. Probably because radiotherapy can stop the microscopic residual disease. Obviously, we are not talking about secondary angiosarcoma. And the final goal of radiotherapy is to maximize the local control, to preserve the chest function, the chest wall, because perform a secondary surgery for relapse cause a series of comorbidity to patients that are very severe. And in general, indication are for tumors that are more than 5 centimeters, close or positive margin. I remember that the margins for breast sarcoma, in general for sarcoma, needs to be more than 1 centimeters. Respect the guidelines for ductal and lobular carcinoma. The disease with a high-grade feature because probably in their pattern of growth they have the DNA in a more radio-responsive phase, and when there is an involvement of the chest wall for the motif that we say for the successive comorbidity after a second relapse. There are some contraindications for sure. Obviously, we cannot perform radiotherapy in patients who have a secondary angiosarcoma, and it is to be avoided also in patients with pathogenetic variants of P53, the patient with leishmania, because there is an absolute contraindication to administer radiotherapy in this patient that can develop secondary tumors. Guidelines for irradiation of breast sarcomas are not specific, but if we can give a look to guidelines for sarcoma in general, we have to administer to patient at least 50 gray, that is the long treatment of 5 weeks, when there is no evidences of macroscopical and microscopical disease. We can escalate the dose on smaller volumes when we have a risk of microscopical residual, or if we have low burden macroscopical residual since 280 gray, that is the most abundant dose that we can administer for this kind of disease. For sure, these are very complex volume, and the patient need to be addressed in center when it's possible to treat this patient with advanced technique, because radiotherapy is not the same for all, but we have now the possibility to administer also more advanced techniques such as tomotherapy, volumetric arc therapy, and also in some cases proton therapy. All these technique that are more recent can preserve a lot the organ at risk and allow us to escalate a lot the doses on small volumes.
Valeria, we need to finish in a couple of minutes.
Two slides. I'm
Perfect.
very brief, so sorry.
That's
And
right.
just an alert for phyllodes, we have to test all the patient before not only the radiotherapy but also the surgery, because this patient can have a pathogenetic variant of P53, but in general is suggested from the genetist to test all the patient with a rare disease. And also in this systematic review of 2019 is reported that patient that underwent radiotherapy presented lower local recurrence rate around 80% respect patient who did not underwent radiotherapy that have local recurrence rate around 20%. Going to future perspective, what we can say for sure, targeting therapies are emerging in general in oncology, and we have even more a lot of drugs that we can use in general in oncologies, but we have a strictly need to have predictive factor to use this therapy also in sarcomas and in breast sarcomas to give therapies that are more tailored for our patients. And we have also to think about possible synergic effect, for example, immunotherapy and radiotherapy. Immunotherapy was tested, for example, in some cohorts in angiosarcoma. Probably in future we have to consider possible combined approach. Another future perspective is to implement multidisciplinary and multicentric activity. A few months ago, we published with an European network of center with a high flow of breast units, a series of 20 years of follow-up of more than 100 patients. And what emerged is that these outcomes of survival are influenced by adjuvant therapy, chemotherapy, surgery in univariate analysis. Also, the emerging status can influence the survival outcomes. And at the multivariate analysis, we have the confirmation that adjuvant therapy can have an influence on outcomes, but probably in this serious patient who have a more aggressive disease underwent chemotherapy, and there is a selection bias. The interesting thing is that histology can a lot influence the prognosis of this patient, and we have an urgent need to characterize this patient even more in order to have more predictive and prognosis factor, also because we have even more artificial intelligence approach in order to combine all this data. And at the end, we can overpass the randomized clinical trials. They have a lot of time, a lot of selection of patients for this rare disease, and we can derive some knowledge also from the retrospective trial if we use them merging from the different center and with artificial intelligence analysis. So going to conclusion, we have seen that breast sarcoma and malignant phyllodes are very rare and can have also aggressive behavior. Chemotherapy and radiotherapy indication have not high level of evidences, but we can extrapolate some indication from soft tissue guidelines. And we have to address the patient always to the center with high expertise in managing sarcoma, because multidisciplinary approach remains essential to manage this patient. And with this, I really thank you for your attention.
Perfect. Thank you for that, Valeria. Great talk. Lots of information. And it's great to see that it's still anthracycline and taxanes that are mainly the mainstay for chemotherapy. Now, the next talk is by Karina Cox. There's been lots of work on the UK guidelines for Phyllodes tumor, and they are out now. They're published. And Karina, we're going to talk to us about the guidelines and about Phyllodes tumor. Karina, the next 15 minutes are all yours.
Thanks, Yazan. So I'm just going to share my screen. So please let me know if you can see this.
All great, thank you.
Brilliant. Okay, thanks very much. And thanks for the opportunity to come and talk about this. So it's also lovely following after Valeria, because that whole idea of multidisciplinary management is really key to this. I'm a breast and oncoplastic surgeon at Guy's and St Thomas's. I'm also clinical lead for breast surgery. But like Yazan, I'm a trustee of the Association of Breast Surgery, and I also chair the Clinical Practice and Standards Committee. So what we've been working on, and it's taken us quite a while to do this, is a multidisciplinary guidance document for the management of Phyllodes tumours, and that's benign, borderline and malignant. Now, this is now published, I'm very pleased to say. It's in the British Journal of Surgery, and it is open access, which means that you can access it without having to pay anything, which I think is really good. And if you look at the authors on this working group, so you can see that there are oncologists, pathologists, radiologists, and this was led by Lisa Whisker, who's a breast surgeon at Worcester. So what I'm going to do is I'm going to go through all of this and present all the most important features of this, because essentially we want you to use this to manage patients with Phyllodes tumours. So I'm going to give a little bit about background, then we'll go on to diagnosis, treatment, we'll talk about surgical margins, surveillance, local recurrence, and again, following on from Valeria's talk, talking about germline TP53 testing. So Phyllodes are very rare. They account for about 0.5 of all breast tumours. They most frequently occur in women in their 40s or 50s. And if you look at what the diagnostic rate is in England, there's about 60 cases of malignant Phyllodes diagnosed every year. And again, from Belen's very good talk about the pathology, these are biphasic tumours. They've got stromal and epithelial components, and we classify them into benign, borderline and malignant. Majority are benign. The borderline is probably the most rare group, and then you've got malignant. And one thing that we've realised, so before we did this work, we looked at surveys of practice, and clinical management of Phyllodes tumours varies very, very widely. So again, that was another real driver for this, for these recommendations, to try and unify practice across centres that treat patients with Phyllodes. So clinical features. So it's usually a symptomatic lump. We always advocate triple assessment, which is clinical examination, radiological examination, and pathological biopsy. You can sometimes see this in a screen-detected population as a fibroepithelial lesion, or sometimes the patient comes back to you because they've been previously diagnosed with a fibroadenoma, which is now growing. I think clinical suspicion is raised if you've had a benign lump excised in the past in a similar area, or if you've had a Phyllodes tumour excised from either breast. Features that increase the risk of it being Phyllodes is a lesion above 4 centimetres, lobulated multinodular appearance on imaging, and as stated in previous talks, TP53 germline mutation is associated with this. Other mutations may be associated as well. Pathology, very briefly, interestingly, fibroadenomas and Phyllodes may have a common origin because they have a MED12 somatic mutations that are in common. And it is very challenging for a pathologist to note whether a cellular to distinguish between a cellular fibroadenoma and Phyllodes. It is very challenging on a core biopsy, and it is pretty much impossible on fine needle aspiration cytology. Again, interestingly, about 18 to 38% of cellular fibroadenomas end up being a Phyllodes, but less than 2% of these are malignant. And sort of going on this pathological theme, it's difficult to distinguish borderline from malignant Phyllodes, and again, distinguishing malignant Phyllodes from other malignant entities within the breast and breast sarcoma can be very challenging for pathologists. Radiologically, mammographic findings are generally non-specific. They may have some ill-defined or speculated borders. On ultrasound, hypoechoic oval, and about 50% are lobulated. But when compared to fibroadenomas, you have this increased lobulation, areas septa, horizontal linear clefts. They can be very vascular with irregular margins. But when we looked at all the available data, and remember this is based on available data and evidence, we did not think that breast MRI would offer any diagnostic advantage in the primary diagnosis of Phyllodes above mammogram and ultrasound. So I'm going to try and whiz through the recommendations in the interest of time. So, and again, this is all open access on the BGS paper. So diagnosis of Phyllodes tumours should involve triple assessment. Core biopsy is recommended rather than fine needle. All Phyllodes tumours cases should be reviewed in a breast MDT meeting. I think given the challenges with histological classification, a second pathological opinion from a specialist centre should be considered. We do not think that preoperative CT staging is recommended for benign or borderline Phyllodes tumours, but a preoperative staging CT chest is recommended for malignant. So you should have a low threshold for diagnostic surgical excision when Phyllodes cannot be excluded on a needle biopsy. Tertiary referrals for suspected or confirmed Phyllodes should be directed to the MDT for review and triage. Management, and this is really key because I think if you look at outcomes for patients with malignant Phyllodes, they're much better if they're managed in a specialist centre. So if you have access to a specialist centre, then it should be within a sarcoma MDT, and shared care between breast and sarcoma MDT is very recommended. The other thing that as a working group we thought was very important to state is that you need to act quickly with patients with malignant Phyllodes because they can clinically progress a lot faster than maybe some breast cancer may progress. So we thought that was very important to state. So breast surgery, so you can offer breast conserving surgery. Again, it's all about getting adequate surgical margins, which I will move on to. You can use complex oncoplastic techniques. And again, it's all about getting good margins. But again, we recommend discussion in appropriate MDTs. You can also offer a reconstruction. But I think patients with malignant Phyllodes, this needs to be carefully considered because if we've got likelihood of local progression, operative recovery time, and other adjuvant treatments. So reconstruction can be considered, but again, with malignant Phyllodes, you need to pay careful attention to these other factors. And again, as well, with malignant Phyllodes, you need to sort of have a really clear idea whether skin needs to be removed, chest wall musculature needs to be removed as well. Now, excision biopsy with a capsule can assist histopathological assessment. And again, another thing to really state, because I have heard of this happening, we would not recommend a vacuum-assisted excision if a Phyllodes is suspected. So management of the axilla, so in a similar fashion to other sarcomas, malignant Phyllodes metastasize mostly hematogenously. Lymphatic spread to axillary lymph nodes is very, very rare. So let's move on to surgical margins. So if you read the paper, there is an awful lot of narrative and review of the literature about this because it has been very controversial to work out what is the most ideal margin. But after consideration of the available data, and we've had lots of discussions, and this was also discussed at the ABS meeting, not this year, but last year, what we have said is for benign, aim for complete excision with the capsule intact. So this is key. You want an intact capsule. And you can discuss with the patient about risks and benefits of re-excision versus risk of local recurrence if the margins are involved after benign. So borderline, we should aim for a clear margin of 5 millimeters. Consider re-excision if it's less than 3 millimeters. And then if you've got 3 to 5 millimeters, again, it's a discussion with the patient, because each patient is very different about whether further re-excision is warranted in that patient's case. But you should be aiming for 5 millimeters. For malignant, we've said aim for a clear margin of 10 millimeters. And again, you've got similar categories for if you don't quite achieve that. And again, it's about looking at your patient, discussing other comorbidities and whether it's the right thing for that patient to have re-excision, or again, we've got other adjuvant treatments which you may consider. So it's very much an individual decision. And again, there is uncertainty in the data. I think anybody who's looked at the data will see that it's not crystal clear. We don't have there is no level 1 evidence, so you're looking at much lower levels of evidence. So I think it's very reasonable to explain to a patient that there is uncertainty in this. So I'm not going to talk too much about this, but adjuvant treatment with radiotherapy, because that's been covered a lot by Valeria. But we do not recommend adjuvant radiotherapy in benign. I think that's pretty self-evident. And again, for borderline, it's not generally recommended, but there may be features of a borderline Phyllodes tumor which may want you to go ahead with radiotherapy. And again, it's all about local control, but this is discussed in a relevant multidisciplinary meeting. For malignant Phyllodes tumors, then we should consider radiotherapy. And again, if you don't quite get your margins, there is room to sort of discuss. So I think if you look at this, there is lots of things that you can talk about, again, within your multidisciplinary teams to work out what is the best thing for that patient. So chemotherapy, there is no evidence for a survival benefit with adjuvant chemotherapy in primary Phyllodes. And again, there's a little bit of data there. And adjuvant chemotherapy is not really recommended in the management of non-metastatic malignant Phyllodes. So moving on to surveillance, because this has implications for resource management. What we have, our recommendation is that if you have a benign, Phyllodes tumor, patient-initiated follow-up is fine. So they do not have to go on to an image surveillance program. For borderline, clinical surveillance every 6 months or 3 years, with a bit of ultrasonography every 6 months, and annual mammography for 5 years. For malignant Phyllodes tumors, it's a little bit more involved. And again, if you've had a mastectomy, then you don't require any further imaging. And again, for malignant Phyllodes, chest imaging, chest X-ray, or low-dose thorax CT is recommended as well for a limited period of time. Local recurrence, so should be treated with further surgical excision and appropriate margins again. So you should aim for your appropriate margins. So again, recurrent Phyllodes, recurrent malignant Phyllodes should be shared care with the breast and sarcoma MDT. You can consider radiotherapy if it's not been administered before for recurrent malignant Phyllodes. Consider small volume, consider metastectomy if you've got small volume oligometastatic disease. And again, metastatic malignant Phyllodes tumor should be managed as per local guidance for soft tissue sarcomas. And we would strongly recommend involvement in clinical trials where they are available. So coming very, very much to the end of this, there are considerations for germline TP53 testing. So women with malignant Phyllodes under 46 years of age, again, with first or second degree relative, you can consider. And again, on this slide, I've put other indications for this as well. And again, women with malignant Phyllodes tumor under the age of 31 should be considered for germline TP53 testing. So thank you very much for listening. I've tried to, in the interest of time, to get through this as quickly as possible, but just to reiterate that this is available, it's open access on the British Journal of Surgery. Thanks so much.
Perfect. Thank you for that, Karina. And if you're all not on one of the WhatsApp channels or the WhatsApp groups, please join, because I'll share the link to the text for that guidelines. It's a great piece of work, Karina, and it's very good for everyone to have access to that. We'll look at a couple of cases, and there's quite lots of questions on the Q&A section. We'll try to do as many of those because we have only about half an hour. And Jamie has a couple of cases to show us so that we can share and see what the panel thinks. So if everybody from the panel they put their cameras on and microphones on, because we'll be asking you questions, because I have no clue what Jamie is going to show us. Jamie.
Thank you. Can everyone see my slides?
Yeah, can see the slides.
Great. So yeah, thank you for the opportunity to talk. My name's Jamie Vatish. I'm a breast surgeon in Birmingham. We deal with a large number of soft tissue sarcomas, and along with my colleagues Selena Baines and Rob Warner, we treat all the breast sarcomas for central England, or the angiosarcomas, I should say. So this is a fairly typical case that we get referred. So this lady was previously treated for a breast cancer in a district general hospital a few years previously. She had a 3 centimeter grade 2 NST tumor, which was ER positive, HER2 negative. She was node positive, and she had breast conserving surgery and axillary node clearance, and subsequently went on to have adjuvant radiotherapy, chemotherapy, and she continued on anastrozole. And that's how she presented. And the local unit that saw her straight away raised the possibility of an angiosarcoma, a radiation-induced angiosarcoma, I should say, and they arranged for her to have a punch biopsy. So that confirmed radiation-induced angiosarcoma, and she was referred to our unit. Her CT staging showed no Mets, which we weren't expecting, obviously, and she had an MRI which didn't show any chest wall involvement. She was 71 and actually quite fit for a 71-year-old lady. So, as we've heard, there is no real solid evidence of how you should approach the management of these surgically. For an area such as this, she obviously needs quite a wide resection, and what I've sketched out there with that black line is the resection margin that we would be looking for. It's 2 centimeter minimum for us for a breast radiation-induced angiosarcoma. In the UK, actually, there's a lot of variation about how to treat these. We tend to be quite aggressive, and any patient with a radiation-induced angiosarcoma will get a radical mastectomy, including pec major, and we would aim to certainly resect the radiotherapy tattoos. Obviously, it is very difficult to resect the entire radiotherapy field. And as we've heard, the level of evidence for this is extremely poor. There's certainly no level 1 evidence. All we have is several case series which seem to suggest that the more radical you are, the lower the rates of local recurrence. So all of these patients that we operate on end up with latissimus dorsi, myocutaneous flap. We also do abdominal tissue advancement to aim for primary closure, and if that's not possible, we do skin grafting to the latissimus dorsi muscle.
Jimmy,
Yeah.
before you show what you've done here, Michelle, what would you do for somebody like this if they comes to you in the Marsden?
Yeah, it's a really interesting question, and it's actually very difficult and varied, and a lot of it does depend on the patient and their fitness. I have to say the approach that we've had a lot more is when a patient presents with locally advanced disease that you don't think you can resect with clear 2 centimeter margins with a simple mastectomy alone. It's at that point we're normally speaking to our medical oncologists and thinking, if this is already locally advanced, actually should we consider a neoadjuvant approach? And in our MDT, we'd be discussing much more about looking at doing neoadjuvant therapy and then considering a radical mastectomy with a plastics reconstruction.
That's where Valeria comes into the equation. But what chemotherapy will you give if you give neoadjuvant chemotherapy for this?
And we have to consider that the patient have 71 years old and she could also have some comorbidities. So probably a monochemotherapy approach, doxorubicin, if she did not underwent before for the first diagnosis in early age, or we can consider the approach with paclitaxel also in a perioperatory phase, some cycle before surgery, with less demolitive approach possible that the patient can tolerate, and then complete paclitaxel dose since tolerance.
Because many of those ladies would have had anthracycline based, and if they had anthracycline in the past, you cannot give them more because they have a lifetime dose of the anthracycline because of the cardiac toxicity. Am I correct in saying that?
Yes, exactly. If she has already performed anthracycline in adjuvant phase, for example, she had luminal B triple negative disease, she underwent anthracycline before she has finished the residual dose. There are also liposomal anthracycline that can be considered, but we are faced on elderly patients. We have to consider it.
I think
And,
we would routinely use paclitaxel where possible.
perfect. That's just
That'd be
going to
our
ask you, Michelle, what would
yeah.
you do in the mass then?
Yes, if we can, we do paclitaxel.
And will there be anything special in pathology that you look for on the biopsies for this? I don't know, Belen, if Belen is still online, it would be great to hear from her. She might not be online, Belen, that's fine. Um, the thing that you mentioned, Michelle, was very interesting is punch biopsy mapping. Would you do a mapping on something like this?
No.
No, perfect. And Jamie, what did you do?
So we went for a surgery first approach, which is generally what we do in Birmingham, but it's interesting to hear about the neoadjuvant option. And I'll explain why. So this is what we resected. As you can see, very large defect. Pec major has gone. All you can see there is the chest wall and pec minor. And we advanced the abdominal skin superiorly, and with an LD flap, we were able to get good closure. However, the reason that I say it's interesting that you would consider a neoadjuvant option is that even with what we thought was a relatively superficial angiosarcoma not close to the chest wall, we had a 1 millimeter deep margin. And obviously, in this setting, you can't use adjuvant radiotherapy. And then, unsurprisingly, this lady had a recurrence not that long after.
And I still remember one of the first cases when I was in SHO a few years ago, seeing somebody who had a radical mastectomy, Haustidian mastectomy. She had everything taken to ribs, and they did not cover her with the LD. They covered her only with a skin graft. And you can see her ribs and everything. I still remember her in clinic. I have a taken photo of her. It was mainly for an angiosarcoma. And in the middle of that, you can see the recurrence. So no matter how extensive the surgery, sometimes it's difficult to know how much, when will they come back. For the recurrence, what will you do?
So we actually took her back to theatre. The recurrence that she had was quite extensive. It was about 6 centimeters or so, involving the chest wall. So she had some ribs resected. In addition to that, luckily we were able to salvage the majority of the LD to get closure again. And I think she was doing reasonably well. This is maybe 18 months later.
And did she have, Jamie, any chemotherapy after your primary surgery before or not?
Yes, yes, she did.
And Valeria, if somebody has a recurrence, will you look at neoadjuvant chemo first for the recurrence before re-excising, or just to go for surgery in your in Rome?
This kind of patient after the second relapse.
Yeah, on the recurrence, if they have a recurrence,
Yes,
do you give them chemo first?
I think that a good approach could be also profiling by biomolecular sites, because we have seen some patients have ALK rearrangement or PDL1. So if the patient is addressed to a high flow level of care, She could also be addressed to agnostic approach if she has some biomarkers and there is a protocol. I think it's the better choice because the other are secondary choice. You can try an approach with single therapy, for example, with gemcitabine if the patient is fit, but we have seen the progression-free survival attended is not so much. So first of all, research of possible biomarkers if there are some trials to which address the patient.
So is there genomic profiling specific for sarcomas?
No, I think that this kind of patient needs to be profiled in center where there is the possibility to high profiling. When you search in a agnostic way some biomarkers for target therapy, ALK is not commonly, for example, research on tissues of sarcoma, but some of them, as Belen also reported, can present ALK rearrangement, so they can address to ALK inhibitors, for example, if there is the possibility of a trial opened for this kind of patient.
And Michelle, would we do something different in the Mazen, or is it similar approach?
I think every patient is different, if I'm honest. I think the biology of this disease is really difficult to manage. You can have patients that you have 2 centimeter clearance margins and they still recur 6 months later. This patient presented with locally advanced disease. You could see that was aggressive at the time of her presentation. And you worry about not just the local relapse after any surgery you do, whether you do a less radical approach or systemic recurrence in these patients. And I think that's why they're so difficult to manage, because you can't predict which ones are going to recur, whereas we have patients with maybe smaller margins that don't recur. And I think it's really difficult for clinicians to manage this with the unpredictable nature. And I don't know if anyone has the right answer.
That's true. We don't want to bore Karina because the next case will be for Karina. Jamie, what have you done anything more, or is that it for this case?
No, I think we can move on to the second one. I do think it's worth saying we've had a few questions on the Q&A asking about re-irradiation for involved margins in radiation-induced angiosarcoma. The answer is no.
Okay, perfect. Short and sweet, the answer. Yeah.
Skip over those. So case two. So this was an 18-year-old woman who was referred to us urgently from a local hospital with a rapidly growing right breast mass. So 6 weeks before she presented, she told us she had a 2 centimeter marble-sized lesion in her right breast. When she attended her local hospital and went for an ultrasound scan, they identified what was approximately a 5 centimeter, what looks like a phyllodes tumor. And then a couple of weeks after that, this is what the clinical presentation was. She had a background of Ehlers-Danlos syndrome and had some associated cardiac issues, and she was currently in further education. So as I said, the biopsy was taken of what appeared at the time to be a 5 centimeter possible phyllodes tumor. The core biopsy showed a B4 spindle cell lesion, so we weren't entirely sure of the histology. The MRI, however, by the time we got to the MRI, we had over a 10 centimeter heterogeneous lesion with areas of necrosis and hemorrhage within it, which is quite a worrying sign. And whilst the lesion was abutting the chest wall, there was no direct evidence that it was invading the chest wall. So when her case was reviewed by our pathologists who have specialist interest in breast sarcoma, raised the possibility of an inflammatory myofibroblastic tumor, which we've heard is a very locally aggressive tumor with very low malignant potential. But either way, our approach was to go for surgery first. So as you can see from the pictures at the bottom, this lady did not really have much in the way of soft tissue to help with coverage of this area. She certainly didn't have enough LD volume to achieve a primary closure. And the picture at the top, what we've marked out with the line around the lesion is what our resection margin was. And because how close this tumor was to the chest wall, we actually excised pec major and the majority of pec minor as well to try and achieve a posterior margin, or as good a posterior margin as we could. Any comments from the panel at all at this point?
So I don't know, Karina, and guys, do you do any of the phyllodes? They're malignant, or do you send them to the?
So we tend to refer, and our referring unit is the Marsden, although I have done one really recently on an obese person with an obese young woman with learning difficulties, Jehovah's Witness, who wouldn't go to the Marsden. So I ended up doing something similar, but I try, it's not my expertise. And we refer, and again, that's something, a big learning thing. If you don't do this very often, unless you've got no other choice, you refer to a unit that does this routinely. So yeah, refer up to the Marsden.
Because I remember when I was in Aberdeen, I did one lady, and very similar story. She was in her 20s, Jamie. She was from the islands. So Aberdeen covers lots of the islands. And the surgeon from there phoned us and said, listen, I'm seeing this mass getting bigger by the day. For the past 6 weeks ago, she had nothing. Now she has something that's triple the size of her breast. So we just shifted her, admitted her, CT'd her, and within a few days, we've done a mastectomy, the bloodiest mastectomy I've done. There's about a liter of blood. Did not have to take pec major, and the plastic surgeon was with me just to get a big flap just to cover her. It was a big malignant phyllodes tumor. And you cannot believe, you admit her for a few days and you can see it growing. When with her top on, you can see the tumor. It's those things really grow at a completely different rate. Uh, Michelle, would you consider surgery first also if this lady comes to you in the Marsden or not?
Yeah, your only option is surgery. You don't really have, as you said, the tumor's progressing in front of you. Anything you do is the tumor's gonna progress through it. Radiotherapy, it will progress through it. There isn't really any chemotherapy option. So unfortunately, you're forced into doing a very difficult operation with limited reconstruction options.
What I found challenging is that they're growing so fast. You stage them, you do a CT scan or PET CT scan, and you will see abnormal lymph glands. It's the abnormal lymph glands because of the amount of inflammation and change.
Yeah.
And if you're not doing many of those, and I wasn't doing many of those, I've done only a couple of those malignant phyllodes, and I've done about 3 or 4 sarcomas. And when you're doing those, you think, I want to take some of those lymph glands out because they look and feel very abnormal, and they're always normal at the end of the day. If they look very abnormal, very big, they brighten up on the PET CT scan. Will you still take some or not, Michelle?
I think, to be honest, that's the big difference between, I guess, sarcoma surgery and most carcinoma. We don't really think about lymph nodes too much, other than a few subtypes, although I do a lot of melanoma as well. But you just need to treat the tumor in front of you. So you've got a rapidly growing disease. You need to manage that. The lymph nodes, you would suspect that this is a phyllodes. It would be incredibly rare to go to the lymph nodes, but it's understandable to be reactionary. So we would just manage the primary tumor. If you're really concerned, maybe get an ultrasound to assess the morphology of the lymph nodes. And I think that's where the expertise of the MDT. So we really rely on our radiologists, who will say these are PET avid lymph nodes, but they have normal morphology, and we don't think they're malignant.
And Jamie, how did you manage to close this? You mentioned.
Okay, so I'll show you some pictures. So this is what she ended up with, a resection. You can just see a very bare chest wall there, ribs and intercostal muscles. Pec major has gone. So my very talented colleague, Mr. Rob Warner, designed this flap. So what you're looking at there on the left-hand side is a lady in the left lateral position. She has 2 flaps orientated longitudinally there. The lower flap is an LD. The superior flap is a scapular flap, which is based on the circumflex scapular artery. So on the left-hand side, you can see the scapular flap there. The circumflex scapular artery has been mobilized up to the subscapular artery, and that will be tunneled underneath teres major. On the right-hand side, you've got your LD. and those have been rotated in as so to close that defect. So our post-operative histology, unsurprisingly, was a 13 centimeter malignant phyllodes tumor. And despite deep resection and taking PEC major and PEC minor, we had a 3 millimeter deep margin. So she had adjuvant chest wall radiotherapy, no systemic treatment. And as we've mentioned before, it's really important to check the genetics of these patients who develop breast sarcomas at a young age.
And Valeria, what sort of radio chemo will you give this lady?
Yes, probably this is a case in which you can discuss, but with very attention also with the patient to perform also some chemotherapy because the patient is young. There is also a close of margins with the deep margins, so I don't know how much only radiotherapy can be radical for this lady because the representation she's not more approachable by surgery way. So is a patient where in a multidisciplinary discussion, personally, I would try to propose and to some cycles of adjuvant chemotherapy. Yeah, I think that also for the age, it's a patient with malignant phyllodes tumor when you can propose it because she has some malignant characteristics, dimension, the contact with the chest wall, also to reduce future comorbidities of the patient in case of relapse. And I don't know if there were other characteristics, grade 3 or other ones.
Now, Jamie, did she have genetics, this lady? Do you have her
No,
genetic?
so nothing abnormal identified.
Okay. Will you wait to get that genetics before you blast her chest wall with radiotherapy? What's the percentage of them being TP53 positive?
Yes, for sure.
Yeah.
I would wait. Sorry, Jamie, the question was for you.
No, I completely agree. I think that's really important.
Okay. And Michelle, will you do the same? Will you wait for the genetics before you give her radiotherapy, or will you crack on with radiotherapy?
No, you'd wait for the genetics. You would want to know.
Perfect. There's loads of questions on the Q&A section. There is no way that we can go through all of those, but I think many of those questions have been partly addressed by the discussion. Now, any comments from the committee? I think Belen has sent her apologies. She had to leave early, and it's great to have her. Michelle, Valerie, and Karina and Jamie, any questions or any final comments?
I just want to say it's an amazing reconstruction they did of that chest with the fat.
It's amazing how they managed to close all that.
Mm.
Yeah, I would agree. Yeah, great work. But I think just to reiterate, we've produced recommendations. They are recommendations, but the key thing is that patient in front of you, working with your multidisciplinary colleagues, and always putting your patient first and working out what's the best thing. But it is, again, it's that thing, getting good outcomes is working well as a team. And if you can't do it, be very honest if you can't do something, because there are plenty of surgeons out there who can do amazing work like this, certainly in the UK. Thanks.
And the other thing to mention is that lots of people talk about fibromatosis and other things. Fibromatosis was addressed one of the previous webinars, I think, rare but benign, more than a year ago. Had a great talk by Michael Boland from Dublin. And there's lots of other things that on the YouTube channel. Now, our next webinar, because October is Breast Cancer Awareness Month, it's mainly about survivorship and about long-term effects. So we have two talks from oncologists talking about long-term effects from chemotherapy and endocrine treatment. And then we have a couple of talks about lifestyle measures, because the more we know about lifestyle measures, the more we know that they're nearly as effective as drugs, especially exercise, losing weight, BMI. So we have another couple of talks from people from across the world. So we will send you the details about those. There will be some webinars planned also for B3 lesions coming soon. And there's lots of other webinars planned. And I always share also discount codes for conferences like Milan Breast Meeting, like the meeting with Hamdi in Brussels, and there's lots of other things. So please, if you're not on one of the WhatsApp groups, I use the WhatsApp groups much more than the mailing list because I manage everything my own. Please don't email me tomorrow or the day after asking for your CPD certificate. I'll send it in a week or two. Just give me some time. And it's great to have still more than 550 people online from all across the world. I was just to say, Karina, Jamie, Michelle, and Valeria, and of course, Belen, many thanks for all what you do. It's been great having you. And Mikhail, Sorotos, and Tatiana, thank you for all the hard work. You've been with us for a good few times now on the webinars, and it's great to have that access for many people with the different languages. Keep an eye on everything. But for people now in the States and South America, have a lovely day. For people in Europe, have a good evening. For people in the Far East and the Middle East, have a good night. And thank you, everyone. We'll see you in a few weeks' time.
Thank you so much.